To be here, and thank you very much to the organisers and to the Newton Institute. It's been a great couple of weeks. So I've been asked to introduce myself because lots of people don't know how to pronounce my name. So it's Deirdre, as if you're daring me to do something, and then it's literally the second syllable which is more important, dre, rather than dree. So Deirdre, I'm not a big fan. Deirdre, it's fine. Deirdre, even better. There you go. And I'm a joint appointment between the University of Warwick and the Liverpool School of Tropical Medicine. And for those of you who don't know your English geography, that is about a 2.5 hour train ride away. But it's working out very well because for me, at Warwick, of course, I have all the epidemiologists in WIDER, great acronym, Warwick Infectious Disease Epidemiology Research, which contains all the all-stars you already know about. And at LSTM, we have, of course, all the tropical medics who are out doing field work. And the Centre for Applied Health Research and Delivery, as in many things, this is all about the acronyms. CARD. CARD is all about really trying to bring science through to delivery. So it's actually, so in terms of mathematical modelling, it's actually trying to do mathematical modelling that's useful for policy in tropical medicine. So we'll see how much I deliver of that in the next few years. And particularly in the tropical medicine context, there are rarely limitless budgets to intervene in an infectious disease. And you want to try and get the maximum impact for the minimum effort. So in a way, we want to do exactly what we discussed earlier you don't want to do, which is optimise budgets, optimise your intervention to achieve the most you want to do. And the implications of a limited budget are things like you can only do so much for so long. And so it's a nice mathematically interesting question. So I've already had one vote of positivity for the fact that this is pretty much a data-free talk. But it does, of course, run the risk of fine-tuning the sledgehammer, which was attributed to John last week. I can't remember who by. But so basically that you're trying to say to them, oh, well, you should do it on a Tuesday when the sun is at noon, and when really, actually, interventions are constrained by things like school terms or when they can get these people out to do that treatment program. And it also runs the risk that we're actually solving the problem for the spherical cow. Okay, so this is it's from a physics joke. We can do the joke later. But basically, the idea is that, you're addressing the wrong policy question or you're misunderstanding how policy is formulated and you're doing your nice little mathematical optimization. And so I'm going to talk about this in the context of an example. This was a project with our colleagues in the Netherlands, so with Don Klinkenberg, Hans Heesterbeke and Roy, and it was very much a joint effort, so I really enjoyed working with these guys, and we had a lot of fun, but it was also one of these classic publication sagas in which we really discovered that you need to make sure that you're addressing the right question and you're not suggesting something, that you're not suggesting that policy is formulated in a way in which it's not. So I'll talk about that a bit more as we go through. So this is an example of integrating infectious disease modelling and economic constraints, but as I say, in a sort of a data-free way, but still informative, I think, for policy. So when I talk to my students, I always say to them, mathematical modelling is used for informing policy, but sometimes it's just about investigating ideas and getting insight, and this is an example of that. So the background when we started thinking about this was that pandemic preparedness plans had no clear objectives. They weren't saying we want to minimise mortality, we don't want to minimise peak incidence, we don't want to minimise peak prevalence, we don't want to minimise peak number of people in hospital. And partly I'm sure that is because they don't necessarily want to spell all of those things out, because it's very difficult to exactly control all of those things in an epidemic. And we wanted to think about how you could control those things and really in terms of social distancing. And this is some data from Martin Bootsma's study of the 1918 epidemic in the States, and also some data from SARS in which they were actually eradicating the infection, looking at how long interventions were in place and how much of a reduction in transmission they achieved. And obviously for SARS, fortunately, they were able to achieve huge reductions in transmission, and really the duration of the intervention was determined by how long it took to eradicate it. Whereas in the US in 1918, it's quite a scatter plot. So there didn't seem to be a very clear idea of how long they wanted to hold these interventions in place. And of course, they did get rebounds and things like that Yes, Seb.
So I know you're quoting this from another paper. So
yeah.
So what happened in Spokane, where they intervened for 12 weeks and had no transmission reduction? Do you know what happened?
Yeah, so Martin's paper estimated that although they intervened, they had no actual impact on transmission. Okay. That's what that point means, if that makes sense.
But you don't.
I can't remember exactly what they tried to do. So, and of course, this contained with any of these sort of social distancing discussions are the impact of behaviour change, which again we raised this morning, so it's very difficult to estimate. So we're going to be looking at controlling these things, but with an understanding that you can't actually control your impact on transmission reduction as well as you might like to.
Is that average transmission reduction over the duration of the intervention?
So if you, so my recollection of the paper, so I would like to, if Martin's watching this, I refer you to the paper. It's in PNAS in 2006. Okay, 2006. It's Bootsma, Ferguson, and maybe somebody else. Yeah, Bootsma, Ferguson. And as I understand it, they fitted models to transmission data from the 1918 epidemic in each location, and they just had a fixed reduction in transmission for a fixed period of time. They estimated what that reduction was and how long it was in place.
Because for the SARS one, it looks like the longer you intervene, the less the transmission reduction.
Well, that's true. So if you have a less of a transmission reduction, it's going to take you longer to eradicate. Because, so for SARS, you're trying to eradicate, whereas for flu, you're just trying to mitigate. So if you have a bigger transmission reduction, then when you're trying to eradicate, you will do it quicker, so you don't have to keep the controls in place so long.
Almost implying that a shorter transmission reduction is more effective, wouldn't it?
It depends. So this is the point. Eradication or mitigation are two very different policies.
It's not cumulative. I thought it was a reduction in the beta over the period, not a cumulative reduction in transmission.
Yes. So yeah, I think hopefully in a second.
Yeah.
Yes, here we go. Okay. This is what we're thinking about. So where you have a period of reduction in transmission. So this is your beta is reduced by a proportion theta phi. I'd not call it phi all the way through the talk. Phi for a period of time d. The duration. Okay.
And that duration is the duration of the intervention as well?
D is the duration of the intervention,
yeah.
The duration of the period for which this is reduced.
That makes sense.
Is everybody clear what the model is?
One example could be school closure. So you might try to run school closure in a reactive sense. You might be acting too late to actually have any effect and spend loads of money greater than.
But is D determined by the epidemic, or is it beforehand?
So we're looking at what happens if you intervene for a certain period of time, D. What impact does that have on the epidemic? And therefore, what might you plan in advance? The reason you wouldn't hold it in place forever is because, in fact, the US pandemic plans suggested that they were only going to keep social distancing measures in place for 12 weeks.
Okay, but
so for example,
it's not if we have brought back stop as soon as the prevalence is below a certain level.
No, so we didn't look at triggering due to the epidemic, so which is an obvious extension of this. And so we tuned the model for basically flu in the UK. So, and we said that we could never get R less than 1. So if you have a baseline epidemic, pretty rapid, pretty slightly unrealistic maybe, and then you think about intervening at different times to different extents. So if you intervene late, 7 weeks into the epidemic, you get this epidemic curve. The earlier you intervene, for the same level of reduction, the smaller your overall epidemic size, and you push it to the right. Okay, so this is something that we all understand. Okay, so depending on when you start your intervention, you have a different impact. You delay your epidemic, which may be good, but also it goes on for longer, which may be bad. And this is particularly true really in the tail of the epidemic. And of course there are stochastic effects as you get towards the tail of the epidemic. So the earlier you start, the smaller your total epidemic size, but the longer it goes on. And if we do the same kind of analysis for starting in the same week, but changing the size of your intervention, the reduction in transmission, obviously the more you reduce transmission in the period, so if you hold it in place forever, the lower your peak prevalence. And again, the longer the duration of the epidemic. So if we do a 2D plot of, on the x-axis we have when the intervention was initiated and how much you reduce transmission, this is how long the epidemic will last. And of course, if you start early with a massive reduction in transmission, your epidemic will last a very long time. But you will have reduced peak prevalence and you will have reduced the total size of the epidemic.
How precisely to define weeks after the onset of the epidemic?
Absolutely. So we just started it with a certain number of people, I've forgotten how many. Of course, stochastic effects would be very important. So we're saying once it's got hold of the population, maybe you didn't know it was there and you start to see an increase in cases.
So how do you specify the duration?
So at the moment, so at this point we're saying you hold it in place forever until there's no cases.
You say the duration of the epidemic?
So the duration is until you've got one case left in a deterministic model.
One case in your deterministic.
Yep, so if I go back here, so here, for example, in this G curve, you know, at 43 weeks or something, we've still got 1,500 cases, and we wait until it gets to one case and see how long then you would have to hold it in place. So that's what the plot is, how long you would have to hold it in place till you get to one. Does that make sense? And so obviously you're not going to hold interventions in place forever. And you could think about some sort of triggering process, but we were interested in sort of predetermining what you might think about doing. So we looked at the US pandemic plans where they said they were going to hold things in place for 12 weeks. And if you start early, then, if you start late, so you start at 7 weeks and reduce transmission by a certain amount, you control the epidemic. But if you start too early with the same level of intervention, when you lift your intervention, you get rebound, and so you get a second peak. And the earlier you do it, the bigger the rebound. And in fact, if you start too early and then lift your intervention, you get practically the same epidemic. Okay. So obviously you wouldn't do that, but the point is that in the pandemic plans, there were suggestions that they were going to start early and for 12 weeks really control social distancing, which suggests that they maybe hadn't thought through all of these things, which is why we laid them out in the paper.
But how about if this is just to wait until the vaccine becomes available?
So absolutely, there's our next scenario coming up. So yeah, this is the same thing about, so the thing I wanted to highlight here is that for the same date of start and different levels of intervention, you can't, so this is desirable on this plot is to have a short thing. This intervention is best for total size and this intervention is best for peak incidence. But these relationships are non-linear. The relationship between how big your reduction is and how long you hold it in place is very non-linear.
Are these intervention strengths something like the ones that you saw for SARS, for instance?
Yeah.
Which ones? All of them, or?
Oh, the values of them?
Yes, I mean...
Yeah, so if you go back and look at the plot, we're down at the bottom here, under 44%. So we're down here. So these were things that were achieved in lots of these cities.
And they had 5 values around which you, about the ones that you are...
Yeah, so the ones that I'm talking about are all below this line, because we're saying you can't get R less than 1.
Mm-hmm.
So, and because we picked an R naught of 1.8, they have to be below 44%.
Mm-hmm.
So all of the values and all the plots that I'll be showing you are sort of below here.
Yeah.
Oh yeah. So, and then if we look at the same plot as before, in terms of the colour is how long the epidemic would last. If you start an intervention in a particular week and achieve a particular transmission reduction, we now have a smaller area where the epidemic would last a long time, and it's a very non-linear behaviour. So, strong and early interventions result in a later peak, a smaller peak, but a much longer epidemic. And no single strategy achieves all of these different things. So no single strategy will give you the minimum epidemic size and the minimum peak incidence and the minimum peak prevalence, and certainly not the minimum duration. And this is really a very simple illustration of things which we all know, but basically showing people that, trying to highlight the fact that you actually need to think about what you're trying to minimise in your epidemic in order to pick the right intervention. And obviously short-term interventions can lead to resurgence. So we decided to focus mainly on a scenario of buying time. So we're saying, okay, so 6 months' time we've got a vaccine. how we're going to minimise the epidemic between now and then using social distancing. So the duration of the epidemic is until 26 weeks. The duration of the intervention is until 26 weeks. And we're going to focus on epidemic size in particular, so the number of cases within the 6-month period until the vaccine is available. So for these kind of interventions, the minimum, so because now the duration of the epidemic is from when you start until the vaccine is available, if you start early and completely stop transmission, you get the minimum epidemic size. But you are going to have to hold it in place for 26 weeks. And then you have obviously a gradient where if you start later with a smaller transmission reduction, you get a larger epidemic size. But there are large areas in here where you have the same epidemic size for quite different interventions in terms of their possible larger scale economic effect. So we thought about trying to optimise this process. So we decided to get a cost function, and one of the biggest problems I think about using dynamic models and economic models together is these cost functions. We really seem to have no good empirical evidence for what these budget sort of cost functions are formulated. And so we're going to talk about total cost in proportion to phi, the reduction in transmission, times by the duration of the epidemic. And I will show some results where we had phi squared and d squared separately. And we're trying to pick the best strategy for a particular budget, which is phi times d. So now we have the same plot I just showed, but we now put lines of constant budget on. And we say, okay, let's say we've got expressed as a percentage of the most budget we could have. So obviously if we have a low budget, we can achieve similar sort of epidemic sizes, but for intermediate budgets, we can have quite a range of epidemic size for the same budget, depending on when we start and how big the reduction in transmission is. And if we plot on the optimal intervention for each budget, you can see that for most budgets, from low to quite high, actually your best time to start is 6 or 7 weeks into the epidemic. Okay? But only if you have very large budgets should you start early. Make sense?
Yeah.
And the reason for the switch, so saying what I'm just saying, is that basically you want to pick an intervention which delays this peak until after the 26 weeks. If you can have, if you can keep a small epidemic in here, that's fine, but if you're starting to get large peaks, you want to move them later. And if we look at this for different cost functions, the same message is coming here. So this is, in some sense, looking at model uncertainty. What's interesting is that regardless which of these three, I think, quite different budgetary functions, you get this same message that around 6 or 7 weeks is the right time to intervene. But this sudden switch doesn't occur when you've got phi d squared. Yeah.
Have you done it without a vaccine?
What you mean, going beyond 26 weeks?
Yeah, because I think you get the same result even without a vaccine.
Wait, when you're looking at a year or... So the vaccine just means...
You have got no other... in this situation, you're shifting the thing into... Because you have another tool that you can use after 26 weeks, 6 months. And so you're shifting it there. But even if you don't have that other tool, if you have no vaccine, I think you still get the same result. And the optimal place to intervene for the short term is at the peak of the epidemic, which is around about 6 or 7 weeks.
Well, it's a bit before the peak. So if we go
you
back,
want
it's kind of
intervene during what would be the peak.
Yeah, it's kind of just before the peak. You want to catch it basically in this period, so that you still have space to do something basically.
The
because if you go too far up here,
peaks at about whatever that is, and you want to be intervening then.
Yeah.
And even without a vaccine, that I think gives you the best option. Is the best option.
Yeah, I think. But then you end up with very long durations, and so in your budgetary, your cost is different. So,
yeah, I mean it's a different problem, but I think you've got there's two things that are happening in what you're seeing.
Yeah, no, I agree.
Practical, but how do you know when week 6 is?
Of course, that's a huge question. Absolutely. But I don't have an answer. So this is the problem with data-free modelling. And the same message comes across for epidemic size, peak prevalence, and peak incidence. Basically the same plots. So really the message from this kind of work was that you should start during the upswing, but you don't have to do it immediately. Did we have any? We did try and get some analytical insights, and we didn't really get very far. So for this audience, we got some analytical expressions, but they were all in terms of cumulative incidence, of course. But I've been working with Andrew Fowler to get some approximations to the epidemic curve, which could then be used in more detail here. But if you want to see the maths, it's all in the supplementary information. But there's lots of maths, but I found it quite unsatisfactory that it was so hard to get a good estimate of cumulative incidence. And in terms of cost effectiveness, if you were to formulate it in this way, depending on how big your budget is, you can have a very big reduction in the total epidemic size if you've got a large budget and it plateaus off here, but the cost per unit reduction, of course, declines and then goes back up again, which are these classic cost functions which we expect to see. And the rebound is caused by this switch between a late and an early intervention. Now, I'm going to do on a little bit of an aside, which was slammed by the reviewers because it was kind of interesting mathematically, but not the right way to think about how to formulate the policy question. So I'm including it as an example of doing something interesting, but it not being the right question. So we wanted to sort of look at balancing costs for stockpiling. So there was, as John said earlier, these 25% coverage of stockpiled drugs were included in lots of pandemic plans, but they weren't really, there was no sort of quantification behind them. And so we just looked at using antivirals purely for treatment, not for transmission. And depending on how much budget you could spend on the intervention, you'd have a certain epidemic size, and that would infer really a stockpile that you needed. So if you have no intervention, you'd need a 36% stockpile, and if you had a large budget, you wouldn't need any stockpiled drugs. And if you actually do the maths to do sort of balancing out all of these costs, if you have the relative cost of treatment versus your budget for your social distancing, so this is the line where there's sort of 1 unit of treatment is equal to 1 unit of budgetary cost spent on social distancing, and then drugs are more expensive or less expensive, you end up with these sort of phase planes where in this area you would, so for a certain budget, depending on the cost of the drugs, you might switch between using a late intervention with a sufficient stockpile of drugs versus no intervention and insufficient stockpiles, this is a bad place to be, versus a late intervention with no stockpile. So obviously when the drugs are expensive, you spend your money on the social distancing, and when the drugs are cheap, you spend your money on your stockpile. And you have sort of interesting behaviour mathematically, and I quite like these plots, and we did lots of them for various outcomes and various budgets, formulations, and but basically the economists said this is rubbish because you stockpile now and you're planning for an intervention in the future, and you need to think about how you discount that future risk, etc. And so you would never actually formulate the problem in this way. And I think this illustrates something that we were talking about this morning about the pitfalls of doing this without talking to the people who actually formulate the policy, or the economists who are closer to policy. So, nice, interesting plot, but not necessarily addressing the right question. So a bit of a spherical cow. I still think there's interesting information in this, but perhaps not as interesting as we first thought. So the results of that sort of analysis is that large stockpiles if drugs are cheap or the budget is small. But basically there are scenarios in which you won't achieve everything you want to, and you may prefer to save your money and spend it on social distancing. What was the point I wanted to make here? So if we want to, so then we thought, okay, well, let's say we've got a particular stockpile. So let's say we've got a stockpile for 25% of the population. How do we, for each week that you wanted to start, how could you minimise the peak prevalence while still achieving a 25% epidemic size? And you can see that there are a range of scenarios. And I've just highlighted this one because we're saying, okay, here's one scenario, here's one what if scenario. I've got 25% coverage of drugs, and I want to start late or early. And the thing is that these differences in peak prevalence, a 1% difference, this is really a doubling of peak prevalence, could be significant in terms of strain on public health resources. So even when you think you've addressed the question of why you've got a certain stockpile, you still need to think about what are the impacts on your health services of achieving that coverage. And in fact, if I redraw that plot in terms of, for a particular week that I initiate the intervention, what peak prevalence would I achieve? You get these kind of non-linear relationships again with this minimum around week 6, and the cost of the intervention is minimised around a similar point. So the delay in introducing your intervention is valuable because you don't waste time during the upswing trying to contain something that you don't need to contain. And of course we looked at uncertainty and parameters, and if you overestimated R0, so if you planned for too high an R0, the epidemic is of course smaller than you expect, and so the intervention is too large. And, sorry, that's a typo. And if you underestimated R0, obviously the epidemic is larger and the intervention is not large enough. But if you'd picked the optimum, so this middle one, you actually, the impact of that is smaller. Okay, so if you have optimised beforehand, you actually are less sensitive to changes in R0, okay, because the optima are similar. And a delay in the availability of vaccine, which is the black bars, it's also minimised by having a late intervention. So if you started early and spent all your money and then have to keep it in place longer because the vaccine is delayed, then obviously that's a worse impact. So this is really just an illustrative example with lots and lots of caveats and limitations. Obviously, stochasticity in the early stage of an epidemic. When is exponential growth? We were using a deterministic model. Huge uncertainty of parameters in terms of severity. You know, if it was a severe pandemic, you might have a different policy. If the transmission was different, you would have to have a different policy. And also the impact of interventions. So what is the impact of closing schools on transmission? And what is the impact of behaviour change on that? And also, I mean, these are all things that we're aware of, but also uncertainty about what are the cost calculations which are made in terms of the impact of an intervention. And in an emergency, of course, budgets are handled differently. So as much planning as you might like to do for this sort of thing, you might still end up doing something very different when faced with it, for the political realities that, again, we discussed this morning. And also, there's unlikely to be one policy throughout, so we're sort of planning in advance for something that might not be implemented at the time. But did we have any useful insights? Well, I hope so. I think so. And they were. The objectives need to be clearly defined, so different policies are required to achieve different aims, and just merely putting it into a mathematical model helps you think about it a bit more carefully. And hitting hard and early may not always be the best response, and I hope demonstrated the value of qualitative insights. And in a national media, famous national media, there was this paper was covered, and I was very chuffed. I didn't know Matt Keeling at the time, and he'd said it was good computer modelling, so I was chuffed. But some people might take this as an insult, but I take it as a compliment. So, like all good computer modelling, the conclusions seem obvious once you've done them. Okay, so that's why I find it quite difficult to present, because it feels a little bit like it's kind of obvious, but actually at the time they were kind of novel insights. So I think this is an example of where qualitative insights, data-free modelling, is actually useful in just reformulating people's thinking. I now then did join Warwick eventually, so obviously I didn't take it as an insult. So I'm just going to talk a little bit more about now trying to apply, because of the things we've been talking about over the last few days and things, about how this kind of approach is now transferring into my work now, about trying to use transmission modelling to inform policy design in resource-limited settings. And in particular, the example of soil-transmitted helminths. You all heard Roy's talk last week, so I won't dwell on it too much. But there's a huge burden of chronic disease, which perpetuates the cycle of poverty, because it's poor people really who are affected. It affects children's cognitive development, their attendance at school, etc. And poorer children tend to be worse affected, although that's a massive generalisation. But the amazing thing is about these neglected tropical diseases is that drug companies are giving huge donations of drugs to be given out in developing countries. And there are opportunities to try and maximise the impact of these donations. We don't think they're going to go on forever, even though the drug companies are actually very keen to, pull these things through to the end. But the question is, how can we deliver these drugs in an effective way to achieve the goals which the countries want? And this is the London Declaration, which was an amazing day that all these drug companies said they were going to try and do something about these neglected tropical diseases. But as with all of these kind of things, this was accompanied by the WHO roadmap for eliminating a lot of diseases by 2020. And the question is, can that be achieved using the tools that they have at the moment? And Roy presented these breakpoint surfaces last week. So I'll just quickly go over them. So how you interpret them. So for example, Ascaris is a roundworm. And if you treat yearly, you obviously get bounce back, but gradually you would want to decline the level of infection. Ascaris is mainly concentrated amongst school-aged children. So provided you achieve fairly high coverage in the school-aged children, you are likely to have a large impact on transmission. And what these surfaces are is any dot in the middle here gives you a coverage that you're achieving amongst school-aged children, adults, and preschool-aged children. So if you're above this surface, then that's a good thing. Okay? So if you achieve high levels of coverage in everybody, then of course you have a big impact on transmission. But there's some balance between how you should cover adults and children. And for the higher the R0, the higher the coverage you need to achieve, so the surfaces are raised. And if you treat more frequently, then the surfaces are lowered. And due to the epidemiology of Ascaris versus hookworm is highest intensities in adults, therefore your coverage in your adults is more important than coverage in school-aged children for hookworm.
What's the third axis?
Preschool-aged children. So under 5 and over 2.
If I've got that right then, so in order to eliminate many of these circumstances, you need to have 100% coverage in school-aged children and so on. So looking to the right.
So if you go to the right, then you don't need 100% coverage.
No, I mean the columns to the right where you've got medium and high transmission.
Oh yeah, in high transmission settings you're in real trouble trying to eliminate just using repeated therapy. Yeah, definitely. So, but the question is how we characterise the R0s from very limited information on prevalence in some areas. So how do we identify where these areas are? That's a problem. But yes, absolutely, there are going to be areas where even if you achieve 100% coverage in school-aged children, you're not going to eliminate these infections. And I think a lot of countries have announced that they're going to eliminate some of these infections, or at least really control them, and it may not be achievable. So we're trying to improve the quantitative insight under that kind of statement. So based on these, which Roy talked about last week, of course we can put economic costs on top of these. So if, for example, getting to adults is incredibly expensive, which we believe it is, compared to getting to school-aged children. So treating school-aged children is easy because you do it through the school system. You can sometimes achieve reasonable coverage in preschool-aged children through the school programme, so you get children to bring their brothers and sisters to school and that sort of thing. But getting adults to take treatment may be quite difficult. But again, as I've been discussing earlier, getting cost functions for these things is incredibly difficult because nobody's really tried to do it and certainly not tried to cost it. And Africa's an enormous continent and trying to summarise these costs across multiple continents is difficult. But of course, so we can project onto these kind of surfaces. So this is lowest cost because you're achieving your coverage really in school-aged children through to high cost for adults. But it's also to do with the demography of the population. So if you have a population with an exponentially distributed population, it may be worth your while finding the adults because there's not that many of them. So it's really, these cost surfaces are going to be informed by the epidemiology, the demography, and any kind of cost function. And as it's also been discussed last week, getting cost functions for if you increase coverage, the cost of that increased coverage as you cover more and more of your population could be any number of shapes. And also you have this effect where when you try and get that last mile, it's incredibly expensive. So that's what we're thinking about at the moment. And one of the biggest problems in trying to do this is when people for these worms are thinking about control rather than eradication. So they're thinking about trying to reduce the health impact on these children rather than necessarily trying to eliminate. We don't understand the relationship between worm load and morbidity. We don't really understand how the distribution of worms would change after repeated treatment. And of course there's uncertainties in the models. And I'd point you to Hugo Turner, just published a paper, looking at how the uncertainties in the effect of, for example, cumulative effort of ivermectin on fecundity for onchocerciasis would affect what interventions you would suggest. So that's basically it. I think constraining interventions is a real problem in low resource countries, and transmission models, even data-free transmission models, do force you to think fully about what problem you're trying to solve and, importantly, what you need to measure. And the dynamics definitely impact the conclusions. So even though we're not trying to fine-tune the sledgehammer, you do need to know roughly which bit of the wall to aim at. And we need to formulate the right question. Are we talking about control or elimination? And what are realistic control program designs? And that may be different in different countries. And what targets of coverage are actually achievable? Again, lots of unknowns, but endless sensitivity analysis can be useful. And I do think transmission modelers like us do have opportunities to contribute useful insights in these problems. So I'm going to finish there and acknowledge my co-authors. And I should also have mentioned, so the outbreaks work with Don, Hans and Roy. And the soil transmitted helminth work is with James Truscott and Roy, but also Simon Brooker at the London School of Hygiene and Tropical Medicine and his group. And we're fortunate to have funding from the European Union, the Bill and Melinda Gates Foundation and the Wellcome Trust. So I'll leave it there. Thank you very much. Any questions? Yeah.
Nice illustration on simple models that these different sort of target things are really different. Minimising total incidence is a sort of natural thing to think about. Minimising peak, I can understand because it's something measurable and maybe to do with the capacity you've got. Minimising duration, why do we want to do that? And does it really matters how we calculate that duration?
Yes, so yes, it's very important how you calculate it, but economic impact. So for example, in Hong Kong, I think definitely one of the things they wanted to do was really finish the SARS epidemic as quickly as they could, because people don't travel to your area, people don't, the sort of larger scale macroeconomic consequences of having an outbreak going on for a long time are quite large. So even though we're talking about the budget of the duration of the intervention, as in sort of the direct costs of closing schools or whatever, you also have the larger scale impact on the economy, or possibly people travelling to your area, or all of those kind of things, which again I'm not an expert in and I would find it difficult to quantify.
True, so for SARS, I can see that's true, but for pandemic flu, would any country have been thinking about duration?
Well, I think once they realised it wasn't that severe, I think maybe some of the pandemic measures they probably didn't want to hold in place for that long. So yeah, I would say that was still a concern.
Sometimes it's a trade-off. If you want to reduce the peak, you're going to increase duration. But if your hospital capacity is limited, it might be better to reduce the peak.
And you don't mind how long it's slumped?
Well, you could do, but you don't want too many people completely overloading the health system at one time. So.
Yeah, it's fair to say we don't know the answer to that one, actually. So, I think naturally your first inclination is that you want to reduce the peak. And that has that, it says it has that impact. But actually, which one is more disruptive? If you've got measures for a long period of time, that actually might be more disruptive than a short, nasty thing that you get over and done with. So we don't really know what the answer to that really is. I suspect most people want to reduce the peak, and that's the thing that the most are worried about.
And what about how we measure duration? What does that do?
So, I guess it depends on, obviously the stochastic tail of any epidemic is very difficult to measure, but maybe it's falling below a level at which you can sort of handle it if it was severe, when you can handle the severe cases, when that sort of drops below a level at which you can sort of start to go back to normality in terms of your hospital capacity. So, but I'm sure logisticians think about these things. But
I'm more worried about if you look at the duration, then probably the population structure is really, really important, which you ignore here altogether.
Mm-hmm.
While for the peak, that's less important, I guess.
I don't think it is particularly sensitive to... There's this funny thing where if you know the size of the susceptible population, I think a bit like your results, and knowing little r is very predictive of when the peak happens, because exponential growth can only go on for so long. So if you think about the epidemic like a Laplace distribution, the two rates are kind of like r and gamma, more or less. So I think you're quite clear on timescales, and the reason no one can predict the peak timing, that's peak time and peak height, you've got no clue. That's very sensitive to population structure. The timing of the highest point is largely determined by little r and the susceptible population, and that's what no one knew in the pandemic, was the size of the susceptible population. But the population structure seems not to matter if you know the Malthusian parameter.
Yeah,
of course
not for the peak and the timing of the peak, but for the duration of the epidemic, the population structure should be incredibly important because that decides where.
No, I think it looks a lot like. I think if you read the timing of the epidemic, like Deirdre's thing, is in roughly how long is it taking to. Because you've got this kind of backwards. It's dominated by stochastics at the end. If you mean really stochastic extinction, yes. But if you mean like roughly how long is it going to take to get to 1% of the population, I think the epidemic is quite well approximated by the Laplace distribution in that sense, right?
Well, I'm now just thinking of a simple configuration model network. I know it's not realistic at all, but the exponential decay of the number of effectives is very much depends on the actual degree distribution of the network. So there is no direct relation between the little r at the start of the epidemic and the little r at the end of the epidemic. That's really decided by the population structure. If you ignore the population structure, you will miss that altogether. So my next question would be seeing this modeling, like what can we say about the population structure, because here I think it is terribly important. And well, you can start by looking at multi-type epidemics, perhaps.
But I guess in practice that means that far off and remote places usually get the disease later than big cities or something, because they're isolated, like kind of 1 or 2 degree people that are out somewhere in the graph. But if you make the epidemic very long and flat, then probably they will be enclosed in this long period. I mean, if it takes time to reach them, they will be within the period, so they will not contribute further. I'm not sure if we can answer these questions within this kind of model. I mean,
no, it depends on the question you want to answer. I don't think the question that Deirdre addressed here is changed in any way if you would have structure in the model. I don't think it's very important here. For this type of broad question, you are trying to say something. It's very qualitative. We're not trying to say anything about when the epidemic would stop, except, of course, the tail would be very difficult to catch, and maybe the beginning is very difficult to catch. But that's all. Once the whole thing gets going, in the matter of in a time course of several weeks or a few months, looking at the whole country, glossing over all tiny details and heterogeneities and.
So actually, no, I think I got Peter saying that. So on a log prevalence scale, the epidemic's going to look a bit like that. But you're saying you kind of need to measure the second slope.
Yeah, and that second slope is depends on the very much on the population structure.
And your intervention might have, because the reason it's funny, the configuration model is to do with how you burn through the high degree nodes or something. And your intervention might have a funny effect on how that.
I mean, our aim was not to say it should be exactly a week 6.2 that you should intervene, right? It's saying you don't want to hit hard and early necessarily. So if you're thinking about these larger questions.
I think that's a very important point itself, actually, and I think so. We've done some, not the same work, but similar, something similar, but But and really, that's why I was asking you a question halfway through. You talk about intervening somewhere near the peak, because intervening somewhere near the peak, even if you don't have something else, reduces overshoot.
Yeah.
So if you can reduce the peak height, then you can reduce the overshoot, so you reduce the size of your epidemic.
Yeah.
And I think that's an important thing. And so if you have effectively then two peaks, a two-peak epidemic, the area underneath that, total number of people infected, is smaller than a single peak.
Yeah.
And I think you were finding the same results, but you had this extra thing about shifting it into when you got the vaccine as well. But I think you actually
I mean, we as it went through various levels of review, and we tried to tailor it more to what people thought were the questions the pandemic do, because we submitted it before the pandemic and then it was under review during the pandemic, so we sort of had to adjust as we went along to address what people thought were the actual questions.
We submitted it actually before the outbreak.
Yeah.
To Nature, and they rejected it.
Then you went infected.
And then they wanted it back again.
We submitted it again to them.
And they wanted it back.
And then they sent out review. Being as they are.
So this is another intervention problem. At what point in the epidemic is it best to submit more papers to Nature?
We thought ahead of time was good, but apparently not.
Not too far before the
We were very prescient.
Obviously, after the epidemic has started, because then there's more public attention, but before it's too late to have some impact on it.
But the issue about this kind of timing thing is, where are you in the epidemic? That's a really important and very, very difficult question. Tom's alluded to it. So it's because you can predict, if you know R0, and frankly we can estimate R0 pretty accurately normally. So if you know R0, then you can know. It sounds like you know everything.
And the longer you wait,
you don't know how you're depleting susceptibles. You don't know where you are in the epidemic. You don't know if it's about to stop, or whether it will carry on going for, because you don't even know how you're depleting it to an order of magnitude normally.
But could we do the study that would help us do that? So surely the purpose of these things is to say, how would we know?
But I think that you chose the wrong scale to look at intervention on, because you did time in a deterministic model.
Yes.
You should have taken proportional population, because that would be measurable with any kind of stochastic variation.
But it's incredibly, but it's much more sensitive. It's way more sensitive to the point that John's making. So how do you know what proportion of the population is affected, really? Because you don't know. So we were saying, because the pandemics were formulated in terms of number of weeks that will hold an intervention in place, rather than when we think we've affected 20% of the population. But if you don't know what proportion are asymptomatic, then you don't know how far you are. So if you, for example, have a trigger in terms of number of cases in hospital to start you, but then have a number of cases in hospital as an end trigger is quite difficult, because you don't know what proportion were asymptomatically infected.
Your interventions worked on asymptomatic people, for instance. I mean, that was
it's a social distancing and transmission reducing intervention, so it does has an impact on the asymptomatics as well as the symptomatics.
It might have different impact on the different ages. So I really do think this is a very good point. Like that, if it's a school closure and it's the primary school age driving it anyway.
Yeah.
I don't think it affects the kind of fundamental insight, which is.
Yeah, I think if you were actually going to use, so the question is, would this kind of approach, but with more detailed models and a study of what you would expect, how would you interpret data, what kind of studies would you do? I just don't think that would ever be used to formulate policy in the UK. I don't know. Would it be?
If you could resolve this problem of susceptible depletion, but I think you need to know how it depletes into the different relevant risk groups as well. So I think it's even harder than just population level susceptible levels. It's in the different ages.
And how you'd measure it.
Yeah.
But are those are these results robust if you look at, for example, Stephen Riley's big simulation models? If you just start to put your interventions in that model, will you also see a length or an increase in duration if you start your intervention at week 1 instead of week 6, and does it make a difference?
I'm sure you will see the same sort of trade-off that that I think is one of the nicest results that you see is trade-off. You can't, as they have in these pandemic plans, you can't have everything that you want as a government, and it simply doesn't work. And you can see that with a simple model, you can show that there are consequences for wanting something.
But what's week 1? I mean, if in week 1 the number of infectious is very small, then in a stochastic model the thing would have died out before.
I mean, I'm not joking. When
No,
I was
well,
working at, you know, when we were I mean, you're going to laugh about this, but this actually happened. So we were, you know, Matt and I and Neil were sitting on this committee, you know, pontificating and stuff, and people were getting in touch with the department because we had this, you know, the department had this plan of, you know, scenario of how things moved, you know, how an epidemic might progress, you know, so that people could plan to it. And then phoning up the department to ask which week we were in on the epidemic. And it's like, okay. Seriously, when they believe it to that extent, you know, well, which week are we actually in? Are we in week 3 now, or no? That was an imaginary epidemic which will never happen. We're now in a real one.
I still think that there are indicators that one could look at, even if you believe that there are symptomatic people that you have underreporting, whatever. The point that you indicated is about where the exponential phase stops, because you reach population level, would the theoretical models say. And therefore some kind of plot of how the exponential speed, when it starts curving down, probably indicates that you're near this point where you reach population levels. You should do log derivative of log
yeah, but that's
cases
exactly,
in hospitals.
and in fact, that's how in the UK. That's how we realised where we were, and that's how we could predict the second wave of the epidemic, because of the growth rate of the second wave, which was in September, was just a little bit slower than the growth rate in June. So you knew you were approaching this point. So you knew that we then, you know, used up a lot of susceptibles, and then the whole thing becomes solvable.
How can you separate that from the beta is just different?
Well, we assumed beta wasn't changing. This was after beta had changed, of course, because in effect, in Deirdre's sort of, we had school holidays, which changed beta, and then, and so what I'm talking about is the growth rate in the beginning of September. So kind of this week, but whenever that was, 4 years ago, whatever it was, the growth rate now as opposed to the growth rate in June, when both times when schools were open.
You assume that in school terms the betas are the same?
Yeah, and so that's what we, and then the growth rate was subtly different.
No, but I guess that you cannot. In fact, that was one of the things debated at the beginning of the HIV epidemic. I remember those Alamos people showed a nice curve going like this, and it was all done with the susceptibility distribution in the population, essentially, during the exponential phase. So you cannot simply from data say that the exponential phase is over, or you have managed to reach other risk groups with less risk. It might be very difficult.
I mean, wouldn't you expect a lower growth rate if it's also 70%?
That's the point. So as soon as you start to see a slowdown in the growth rate, it's telling you something about how much of your susceptibility you've exhausted. Because you counted cases, but you don't know the relationship between counting a case and how many susceptibles have been depleted.
We know this picture can't be quite right because there was a third wave.
Yeah, that's a different point about us not understanding fluid immunity.
There are several indicators of in which you can measure. I remember I put around with generation time, still in models, I mean, never real people. And there's a strange effect. Just when an epidemic starts to grow, you've got shorter generation times because of the kind of demographic effect. And then, if you look at them correctly, they start increasing. And if you look at simulations, there's a kind of flat phase, which is the exponential phase. You get the same coefficient, and then it starts growing again. So average length of generation times is in theory an indicator, once again, starting to reach the population level.
So we don't, in a normal thing, we won't measure it, yeah.
Average length of it.
Especially when there's a lot of people infected, then it's difficult to work out who infected somebody. So
and it has to be measured backwards. This is the backward generation time that you then have to monitor.
Surely, in practical terms, it takes a couple of weeks to notice that something's happening, a couple of weeks to decide what you're going to do about it, and a couple of weeks to organise an intervention, by which time you're at week 6, and it's the ideal time to do something.
Quite right.
So then we should do things as soon as possible.
More or less, yeah.
It also raises the question of just letting it go a bit longer so you can measure a bit more.
Yeah, we tried that.
Yeah. That didn't go down too well, I'm guessing. You know, people don't
tried
like that.
suggesting that one.
So, maybe you did talk about this and I missed it, but presumably you don't know the effect of your intervention on beta. Basically, you don't really know in advance what that effect is going to be. So, is there any general insights that you got from this that you could apply to not knowing what the effect exactly might be, and especially considering that you might even be so lucky to knock R0 to or knock the effective reproduction number to below 1.
General insights in terms of how you would design
in terms of how you would plan your intervention, when is the best time to intervene? Because presumably, so you didn't include the fact where you get R0 to below 1, but presumably if you do that, then the epidemic just stops and you
but then you have a bigger chance of rebound, right? So it depends if you were concerned about importations or not. If it's really a global pandemic, you know, if we imposed controls to such an extent in the UK that we stopped all transmission, when would you lift it?
Yeah, so many susceptibles left. Some people are coming from outside.
Right, but say you have contingency plans for a 12-week intervention, and you don't know basically how strong your reduction in beta is going to be.
Yeah, so I think in reality you might have a system of introducing things sequentially until you achieve the sort of result that you're looking for. So you would say first of all maybe school closures, maybe large gatherings and things like that.
I think with school closures, that's the one area where we do have a measure now. I think largely because of the pandemic. But I think we do have a measure now of how that affects overall transmission. We can have a reasonable stab at what was it fine in your model would be for school closures, and that's the most obvious one to.
How effective was it?
It's extremely effective.
Because we considered that if you close schools, they'd probably all go to the mall and hang out their friends.
Well, no. I mean, the reason why I say it's extremely effective is really by the accidental experiment that we did, which was to close school here in the UK, which was to close schools because it was summer holidays. Not to close schools, but to close schools because of the summer holidays, and that stopped the epidemic in its tracks. So we were, a bit like, very much actually like some of the simulation sort of thing you've shown, you're really at the exponential growth phase, it's raging, and it dropped like a stone almost, and then started again in September when we opened it again.
Yeah, but that's exactly my point. I mean, surely that got the reproduction number to below 1.
Yeah, it did, yeah. Whether it would have got the reproduction number to below 1 at the beginning of the epidemic is not quite clear. Yeah, so there's a sort of about maybe 40% reduction overall in the reproduction number. We tried to estimate this, so maybe something like that. And if the reproduction number is about 1.45, 1.5 or something like that, then you might bring it to something close to 1. But by the time we actually did do it, we of course learned through quite a lot of susceptibles as well. So the effective reproduction number had already been reduced by the epidemic itself, and then school closure was extremely effective.
Have people completely excluded climate factor, which was discussed for some time?
Well, it obviously didn't seem to have a lot of an effect, did it? Seeing as we essentially had this enormous epidemic in June and July. And I know, it's not Italy, but.
And this point on a more theoretical question, how does this relate to the idea of pulse vaccination and skipping epidemics?
So you're saying trying to optimise how often you do the pulses?
Because it's kind of the same effect that these guys are working with.
Yeah. So there's a particular time in the season that you should do pulsed interventions. So in Nick Grassley's paper in Prof on pulse vaccinations, he discusses it, and also Lucio Kell's mass drug administration for malaria paper, she discusses timing, and there's a few other papers basically that cover the issue with a seasonal epidemic. If you're going to do a once a year pulsed, when should you do it in relation to the timing of the peak? And again, it depends what you're trying to optimise across many years. So yeah, it does apply for those kind of scenarios. And there are lots of papers on that as well.
Sure. Can I quickly follow up on the school closures questions? Because can you have any information, given that you had this natural experiment of the summer, right, on what was the contribution of the fact that school goes off during the time that people take vacation and leave towns, and basically you don't have the possibility of kids accumulating in malls and in some other places because everybody's taking their family vacation,
Yeah,
right?
so
Because it's not necessarily going to happen if it happens in
I agree
October.
that summer holidays are slightly different to other holidays, so, and we actually measured that as well. So when we were doing that, fitting our model to the data, one thing we forgot when we did the projections for the autumn wave was half term. So half term in the UK happens at sort of end of October. We completely forgot about that. And that was actually when we were predicting the peak of the second wave. And indeed it did peak around then, but then the half term came in and sort of had an extra effect. And but the effect of the half term, if you try and reconstruct it and estimate how, and I don't know whether others did this, we certainly do, the effect of the half, I think somebody else did this, but I forgot it. The effect of half term was less than the effect of the summer holidays. There is an additional effect of summer holidays, yes, people go to Spain or something where there was plenty of epidemics going on, by the way, and so on. Yeah, so there is some additional effect. It's not just the schools are closed and the stuff, but primarily it's.
But even before closure, you have a clear signal in
half term.
Yeah, it's half term.
Yeah.
If you look at other data, so you can intuitively go what a kid's going to do. If you look at the data which exists in England today, actually really exactly where children actually go to primary and secondary schools. Firstly, they pull in quite a lot of it, so they connect different communities. Right? It's quite difficult. Got quite a complex network of journeys of children to and from school. And also, certainly primary schools, but probably even adolescent friendship networks just aren't as big as the school. Right? It was kind of obvious when you said it, but they were a class of primary school kids, there's 30 or 40 of them, and they're all over each other. So my colleague Andrew Easton at Warwick got to do something which I think he probably couldn't do if it was research, but he did it on the telly, and he sprayed this luminous spray that was like a sneeze in a primary school classroom. Got a telly crew, so you can see this on the BBC website, to film these kids walking around, and turned off the lights, and they're all glowing with this, glow in the dark stuff, because they spear the gunk all over each other. Man. Primary school, certainly primary school age, if you look at measured sort of social behaviour of kids, it's nothing like rubbing their mucus all over 30 other kids. Right? What parents will arrange or what they'll arrange at primary school. And I think teenagers as well are far smaller. Left to their own devices, they're far smaller social interaction groups than they'd get at. That's because in that sense there's corroborating evidence to that intuition that says actually it's not going to be such a big stochastic amplifier of infection.
We did measure contact patterns. So we had a couple of studies during the 2009 pandemic where we measured contact patterns during the course of the epidemic, and so we could measure the impact of school closure, but primarily it reduces contact between kids. There is some secondary effects where you can see some increase in contact between kids and other age groups that sometimes occur. Can also measure the slight increase in contact between kids at different schools. So there's actually a link between others. So when school turns on, you meet kids in your school, not very many kids from outside. And when the school holidays are on, there's slightly more contact with kids from other schools.
That's what I was going to ask. I mean,
but these are very small secondary effects. But the dominating effect is the reduction of kids to kids contact.
I think we might. I think we're going to stop now, unfortunately, but do carry on in a second.
Let's go.